Hello, everyone. Welcome to today's live broadcast, Improving Diagnostic Testing and Interpretation of Chronic Kidney Disease, presented by Dr. Kevin Martin and Dr. Stuart Sprague. We are excited to bring you this educational web seminar presented by LabRoots and sponsored by Siemens Healthcare. Siemens Healthcare is one of the world's largest suppliers of medical infrastructure and is a leader in medical imaging, laboratory diagnostics, and clinical IT. For more information, please visit www.siemens.com/healthcare. I am Brenda Kelly Kim of LabRoots, and I'll be your moderator for today's event. Before we begin, I'd like to remind everyone that this event is interactive, and we encourage you to participate by submitting questions whenever you want during the presentation. Just click on the green Q&A button located in the lower left of the presentation window and type your question into the box that appears on the screen. We'll answer as many questions as we have time for at the end of the presentation. Also, please notice that you will be viewing the presentation in a slide window. To enlarge the slide window, just click on the screen icon located in the lower right. Finally, if you have any trouble seeing or hearing the presentation, we want to know about it. Click on the support button at the top right of the presentation window or use the Q&A button to let us know you're having a problem. This webinar has been approved for continuing educational credits. Please click on the CE button at the bottom left corner and follow the process to receive your credits. I'd now like to introduce the first of our speakers, Dr. Kevin Martin. Dr. Martin is the director of the Division of Nephrology at St. Louis University and professor of internal medicine. He has served as chairman of the General Medicine B Study section of the National Institutes of Health. Dr. Martin's clinical research interests include parathyroid hormone, vitamin D metabolism, and secondary hyperthyroidism. He has authored 230 publications in professional journals, including the New England Journal of Medicine, Kidney International, and the American Journal of Kidney Disease, Clinical Journal of the American Society of Nephrology. We also have Dr. Stuart Sprague with us today for this webinar. Dr. Sprague is Chief of the Division of Nephrology and Hypertension and Director of Nephrology Research at North Shore University Health System and Clinical Professor of Medicine at the University of Chicago, Pritzker School of Medicine, Chicago, Illinois. His clinical focus includes chronic kidney disease, end-stage renal failure, osteoporosis in chronic kidney disease mineral and bone disease, and hyperparathyroidism. Please join me in welcoming both Drs. Martin and Dr. Sprague. I will now turn the presentation over to Dr. Martin to start.
Thank you, and hello to everybody. I'm going to spend this part of the presentation to talk about clinical chemistry assays that are used in patients with chronic kidney disease and spend most of the time talking about parathyroid hormone and vitamin D, which continue to be the most problematic. So in a general way, the clinical chemistry requirements for following patients with chronic kidney disease are many and have varied and evolved a little bit over time. You can see that, of course, the measurement of creatinine and estimates of GFR are important to stage the kidney disease, and these continue to be the mainstream of assessing progression. Other markers are up and coming, such as cystatin C, for example, but probably not in the mainstream at this point in time. And the formulae for estimating the GFR may also undergo evolution. We currently use MDRD formula, and this may gradually morph to a different equation, CKD-EPI, which may be a little more accurate at higher levels of GFR. But for the moment, I think creatinine and eGFR by the MDRD formula are in the mainstream. The lab also needs to be able to measure protein in the urine or microalbumin to be able to perform accurate urinalysis for identification of cells in the sediment. They need to be able to evaluate lipids in blood and glucose. Uric acid is important, as well as general hematology. And clearly, frequent requirements for measurements of BUN, creatinine, and the other electrolytes. We also have a need for measurements of serum albumin and 24-hour urine, either urea or sodium. There's a necessity for iron panels, and of course the antigens and antibodies for hepatitis B and C. But what we're going to focus on most today is these last ones that are here of calcium, phosphate, alkaline phosphatase, and spend most of the time talking about parathyroid hormone and vitamin D. So let me begin by talking about PTH assays. So just as a refresher, we can see here in the diagram that parathyroid hormone is an 84 amino acid peptide, and its main function is to regulate the concentration of calcium in serum. If there is kidney function present, as there is throughout most of chronic kidney disease, parathyroid hormone also increases phosphate excretion in the urine, and so lowers the concentration of phosphate in blood. The biologic activity of parathyroid hormone is contained within the first 30 or so amino acids, and the first few amino acids here are highly critical for any biologic activity. The remainder of the hormone is not believed to have any significant biologic activity at this point in time. So by way of history, you can see that PTH assays have been around since the 1960s, where it was really done by radioimmunoassay, and this was a tidbit of things to come and problems with PTH assays. And initially, the antibodies were directed towards the C-terminal region of the PTH molecule here, and they didn't perform very well as the issue kind of evolved. And so the next step was to try to find different antibodies, and it turned out that assays and antibodies with determinants in the middle part of the molecule were somewhat better and seemed to behave well clinically. However, that seems at odds with the idea that the biologic activity was in the N-terminal 30 peptides or so, and of course assays were introduced that would be directed towards this portion of the molecule, but suffered from lack of sensitivity and irreproducibility, and really were not satisfactory. So the major breakthrough in PTH assays came just at the beginning of the 90s, where the first of the two-site antibodies was introduced, believing that this would capture PTH from serum usually with the C-terminal antibody, and then detected with an N-terminal assay. And this was believed to measure only the intact peptide, and so currently go by the name of intact PTH assays. But as I'll show you, they measure more than just the intact PTH peptide itself. And then the most recent development is to try to develop antibodies which were with the detection antibody very near the N-terminus, right within the first 4 amino acids, the so-called second-generation immunometric assays, which should really reflect more of the biologic activity that we're interested in trying to quantify and measure. But the problem with PTH assays is really because of this, that there's not only PTH, the 1 to 84 peptide, circulates in plasma, but there's also a variety of truncated PTH peptides that also circulate, and these vary from the region of their specific N-terminus, and I'll say a little bit more about that later. But they continue to cause problems in the assay to be sure you don't have cross-reactivity with these other fragments, which may not have biologic activity. So, of course, it was of interest to find out where these fragments came from, and we know that the PTH is synthesized and stored within the parathyroid in these secretory granules, and then with a stimulus of calcium falling in the blood, there's a stimulus to secrete the hormone, which it does, and secretes the intact 1 to 84 peptide into the circulation. If the calcium is high and there's no need for PTH secretion, a degradation pathway is triggered within the parathyroid cell, which begins to produce these parathyroid fragments devoid of biologic activity within the cell, and these can be, under certain circumstances, secreted into the circulation. So that, again, to emphasize that in the circulation at any one time, you have a mixture of fragments of PTH as well as the intact 1 to 84 amino acid peptide. And just by way of historical example, this was from direct cannulation of parathyroid glands in cattle, sampling the blood, draining the parathyroid, and fractionating immunoreactivity according to molecular size. And you can see that in the middle panel here, there's approximately equal proportions of intact PTH, which is at the arrow there, and lower molecular weight C-terminal fragments. If calcium is low, in the left-hand panel, there's a much more intact PTH than fragment. And conversely, if serum calcium is high, there's very little intact PTH, and all of that PTH peptides that are secreted from the gland are actually inactive fragments. So the fragments can be generated in the parathyroid and can be secreted under certain circumstances. But to complicate the issue, these fragments can also appear in the peripheral circulation, as shown in this experiment here, where an injection of intact PTH is given to an experimental animal, and you can see in the green line there's a gradual appearance of PTH fragments that accumulate over time. So the bottom line of this is that PTH fragments can complicate the assay. They come from the parathyroid gland and from peripheral metabolism of the peptide, and so cause challenges in how to get a valid index of parathyroid activity in serum. And so over the years then there's been several two-side assays that have been developed for this purpose. Most capture PTH by a C-terminal antibody and use varying detection antibodies to some region within the first 30 or so amino acids. And as I mentioned to you, because of this one labeled 7 to 84, which is actually a family of PTH fragments, if this is detected by your assay, then it can cause significant problems, as we'll get to in a minute. So to try and avoid that, I have mentioned these newer assays with the detection antibody directed right at the very N-terminus, which should, at least theoretically, give you the most reliable index of biologically active PTH in serum. So the why this becomes important is illustrated in this slide here, which gives a hypothetical example, although you certainly can validate this in vivo. If just for a moment consider that we have an intact PTH value of 500, this could represent 250 picograms of PTH 1 to 84, the active peptide, and an equal quantity of the biologically inactive 7 to 84. Or, with a total PTH of 500, could represent 100 of PTH 1 to 84 and 400 of 7 to 84. Or, as shown in the C column, it could represent 400 of intact PTH and only 100 of the PTH fragment. So all of these will give you a total PTH value of 500 if the PTH assay also detects the PTH 74 family. And indeed, that happens quite a bit. And the complication occurs in patients with kidney disease because, unlike the situation in the normal patient where there's a relatively low amount of this PTH 7 to 84 family, shown here in the yellow slice of pie, in chronic kidney disease, where all these fragments accumulate, the proportion of the 7 to 84 fragment to intact PTH can become approximately equal, although there's great variation on either side of this. So you can see here the difficulty of trying to measure biologically active PTH, the red slice of the pie, in a whole sea of PTH fragments, and requires a detailed knowledge of the specificity of the antibodies used in the assay in order to obtain a meaningful result. So again, just illustrated in a different way, we have many PTH peptides in the circulation. We're trying to measure these with a capture and various detector antibodies, and the site of action of the detection antibody is really critical to what might be measured. For anything that measures from 7 on is likely to measure some of the 7 to 84 family. And perhaps, as I mentioned to you, more specificity can potentially be gained by assays that are directed with the detection antibody right at the very end terminus. So you can see in this complicated sea of events can cause tremendous confusion on a clinical level. So here are various commercial PTH assays that are available, and it gives you an idea of the between method differences in concentration of parathyroid hormone that you might get in a single PTH sample. So they range here from 54 in this particular assay shown at the top to a value of 183 as seen here in another assay. So all of these assays going by supposedly intact PTH assays, and are supposed to measure just the 1 to 84, but in actual fact, the significant detection of the 7 to 84 PTH peptides. So you can see that there's a greater than threefold range in PTH assays, and you can begin to imagine how difficult it's going to be then to try to get a meaningful comparison between labs. And we're going to talk about this in terms of practice guidelines in a minute. So this variation, to a large degree, is related to the ability of the assay to measure and detect these 7 to 84 family of peptides that I mentioned to you. And I think it's clear from the slide here that the ability of the various commercial PTH assays to detect this family of peptides varies large, but most assays detect it to some extent, except the ones on there on the bottom, which have a detection antibody at the very end terminus of the PTH molecule. So with this great variation in mind, you can see how difficult it is to make clinical practice guidelines. And for this issue of progressive hyperparathyroidism in chronic kidney disease, there's been 2 attempts to try to make clinical practice guidelines. The one I'm showing you here is one known as KDIGO practice guidelines, sponsored by the National Kidney Foundation, but now a worldwide effort. And they have come with a refinement, really, of the various practice guidelines that have been around. So the 2 sets of guidelines that exist are the so-called KDOKI guidelines on the left and KDIGO guidelines on the right. So the KDIGO ones are older and recommended a target value for intact PTH assays in patients on dialysis to be in the 150 to 300 range, with calcium in the normal range, phosphorus from normal to slightly high, and to consider a calcium phosphate product of less than 55. So these were the best available data at the time, but the assays that gave rise to this suggested range really don't exist anymore, and so this was based on fairly weak data and an assay that can't be verified under modern therapeutic regimens. So the KDIGO guidelines on the right were an effort to refine these targets. And taking into account the variation in detection of the various assays that I've described, I tried to suggest that maybe what should be best is to factor this by the upper limit of the normal range, and suggested a reasonable range in patients with chronic kidney disease and dialysis to be somewhere between 2 to 9 times the upper limits of normal. And I'll come back to talk about this again in a minute. Like the initial guidelines, they want calcium values in the normal range, and suggested maybe that we can do a little bit better with phosphorus control and try and get it more towards the normal range, which would be approximately 3.5 to 4.5 in most clinical chemistry labs. So a little more stringent control of phosphate is desirable. So the trouble with these, the variation in the assay is that if you try to adhere by the KDIGO guidelines, and the details of this slide are not important specifically, except to say that depending on the particular assay used, it will lead to differences in classifications as to whether the patient is within the guideline or without it the guideline. So it becomes an important issue to try to help those ordering PTH assays and to interpret the result and to try to have them categorize the patient appropriately. So to summarize this, the target PTH range recommended in KDOQI was this 150 to 300, based on studies during the early 90s with the PTH assay that we know is no longer available to us. And so more recent studies with the different PTH assays that are available have confirmed that PTH levels are associated with bone turnover, with cardiovascular disease and mortality, and the range stratification for risk has been defined further, and knowing that there's an increase in mortality if PTH is too low, as well as an increase in mortality if PTH is too high, and suggesting that we focus in more on this range and try to use this and to correlate this with the various assays used. So the big question is then, are these target ranges useful regardless of the PTH assay? And you can imagine that by what I've told you so far that the answer to that is probably no. And we need to solve the problem better. So one issue is, could we standardize PTH assays? And in an assay that detects these family of inactive fragments, the 784 family, with varying degrees of efficiency, makes the goal of standardizing PTH assays almost impossible. So should we try to apply correction factors and try to get everybody more or less within the same ballpark of this? And that may be helpful. Or should we just try to define the targets that are specific for a given assay? And that would require that the clinical labs report which assay they're using. And as you know, that's not always done, although as we'll say towards the end, that's a particular goal of some of the nephrology societies. So it was to try to get around this that the practice guideline group tried to factor this in terms of upper limit of normal, and suggesting that in the range of 2 to 9 times the upper limit of normal may cover most assays and maybe give rise to values that are within the desired target. So if you're going to factor things by reference value and your normal range, so to speak, then you need to pay attention to how you get the normal range and what are the criteria used, whether was it a rigorous population or one that was just convenient. So we really need to exclude the things that we know regulate PTH or are associated with changes in concentration. So we need to know that the patients for the normal range reference value determinations are not hypocalcemic, are not hypercalcemic, have relatively normal kidney function, are not taking medications that can interfere with calcium control or vitamin D metabolism, and don't have any disease of calcium metabolism, even such as hypercalciuria, and are taking a reasonably normal intake. And nowadays we have to pay attention to their vitamin D status, or should we make sure that they're not with low levels of vitamin D, which has the potential to increase PTH. So just to illustrate this, in these studies by Cavalier and others, here's a comparison between manufacturers' reference ranges and a reference range found by Cavalier and colleagues in a carefully defined population such that I've described. And you can see that if you start here on the bottom, it makes quite a bit of difference. In this assay, the manufacturer's reference range was 12 to 88, whereas with the Cavalier normals was 10 to 47. So some of these values are dramatically different, some not so dramatic. But as you begin to multiply these by factors of the upper limit of normal, you can see that different ranges are going to result. So if we want to target this KDIGO suggestion based on the manufacturer's reference values, you can see for this assay up here, it would be, say, 136 to 612, but based upon the other normal range was 130 to almost 600, not too bad. But this last assay would have values up to close to 800, but if the normal range is different, it would be closer to 400. So you can see that it does make a difference with some assays, and not so much with others. And it just calls attention to the fact that we need to pay exquisite attention to how the normal range was developed. So to go back to the guidelines and leave PTH, for example, for a moment, the guidelines also suggest that we need to pay attention to the vitamin D status, and suggest that 25-hydroxy-D levels should be measured in these patients, since it's a well-known factor that could affect parathyroid function. So the lab needs to be able to measure 25-hydroxy-D, and repeat testing would be required if there's any therapeutic intervention. And the initial stab was to suggest that we should try to take these values and treat it according to the recommendations of the general population. So we know that 25-hydroxy-D is the metabolite that measures the vitamin D status, although there are slight differences in the definition of vitamin D deficiency and insufficiency depending on the group. For example, the Institute of Medicine suggests a range of normal of above 20 nanograms per ml on the one hand, while the Endocrine Society would say that has to be somewhat higher than that, and would take the lower limit of normal as 30. So in general, I think most of the nephrology community would think that they would try to get at least above this 30 nanograms per ml value, and will try to institute various therapies to try to achieve that goal. So the practice guidelines state here, in patients with CKD from 3 to 5 and on dialysis, 25-hydroxy-D might be measured, and repeated determinations, depending on the therapeutic intervention, will be required. And they suggest that vitamin D deficiency and insufficiency be corrected using treatment strategies mainly directed towards the osteoporotic population. This is an area that's undergoing revision constantly. There's many clinical trials to show this. I know you can't read the details here, but it shows you that there's many trials of trying to correct or look at the effects of vitamin D supplementation. There's variation among the trials, but in general, the studies to the left of this vertical line here, get this vertical line here. I can't seem to highlight the line, but let me get it. This shows that the suppression of PTH when you achieve correction of vitamin D insufficiency or deficiency. But a big controversy continues as to whether this is meaningful and beneficial to the patients. But in general, there are some areas that seem to stick out. Here you can see that it does perhaps lower proteinuria in patients, so this is an important area that needs further study. We have also data to say that this might lower PTH and help with PTH control. It seems to be safe. It affects various bone and mineral markers, and the hesitancy is that it may not. There's no solid data to know that it influences mortality in these patient groups. But it may well be helpful in the general setting of kidney disease by this decrease in albuminuria that I mentioned on the last slide. It may be important for the progression of kidney disease, and it may be important in some other aspects of inflammation and inflammatory markers, etc. So this is an ongoing area that's awaiting more definitive clinical trials as we go forward. But so I think but both for the vitamin D assays as well as for the PTH assays, it was felt in the Nephrology Practice Guidelines Committee that we need to be aware of the variation that can occur, and they recommended that the clinical laboratories would begin to inform the clinicians of the particular assay method used and to report any changes in methods or handling that might occur, so that the clinician can have an idea that some assay parameter has changed, that there may be differences in their ranges and expectations, so they can adjust their clinical practice accordingly. So far, this has not been widely implemented, but there may come more recommendations to do this as we go forward. And so, in conclusion, I will say that PTH and 25-hydroxy vitamin D assays are currently routine measurements in chronic kidney disease. The PTH assay continues to be problematic with inter-method variability. I mentioned the issue with appropriate reference ranges and, of course, sample handling and individual variations. There's a necessity to measure various bone markers to complement PTH, and currently the most common one is alkaline phosphatase. There's new markers on the horizon, such as FGF23, sclerostin, perhaps, bone-specific alkaline phosphatase, or maybe markers of osteoclast activity that are currently being evaluated in this area of the disturbances in bone and mineral metabolism and CKD, and have not been incorporated into the routine clinical laboratory assessment at the present time, but probably will be in the not-too-distant future. So with that a brief overview, I'm going to stop at this time and hand you back to the moderator. And thank you for your attention.
Thank you, Dr. Martin, for bringing that information to us. For more information on the topic of chronic kidney disease, we're now going to turn to our other speaker today, Dr. Stuart Sprague.
Good afternoon, thank you. I'm going to try to follow up here from Dr. Martin and try to give you how we deal with this clinically in taking care of patients with chronic kidney disease. I would like to start first going over some of the pathophysiology associated with the development of chronic kidney disease. As we start to decrease or lose our GFR, we start having phosphate retention, not necessarily hyperphosphatemia. And with that phosphate retention, we actually get an inhibition of calcium, or the ionized calcium tends to drop. We also get an inhibition of calcitriol, both from the increase in phosphorus, as well as it used to be thought, though there's other factors that play a role there in decreasing GFR, but the decrease in calcitriol, the decrease in ionized calcium, and the increased phosphorus actually both help to increase the production and release of parathyroid hormone. In addition, there tends to be a resistance of the skeleton to parathyroid hormone, where they actually need a higher parathyroid hormone concentration in order to stimulate the bone remodeling and cycle. So this all leads to hyperparathyroid bone disease. In addition to what's happening in terms of parathyroid hormone, we now know that with decreasing GFR and phosphate retention, we get increases in the phosphaturic hormone fibroblastic growth factor 23, or FGF23. FGF23 is also a potent inhibitor of calcitriol production by inhibiting the 1-alpha hydroxylase. In addition, FGF23 does have some effect in inhibiting parathyroid hormone, but that inhibitory effect on parathyroid hormone is greatly overridden by the stimulation of increased PTH by the decreased calcitriol, increased phosphate, and decreases in ionized calcium. PTH also goes and stimulates FGF23. We also have the production of another protein, matrix extracellular phosphoglycoprotein, which is induced by FGF23, and there's actually some evidence that this MEPI may actually interfere with bone mineralization. So at the level of the skeleton, we have the effect of the high parathyroid hormone causing hyperparathyroid bone disease, as well as other factors potentially mediated through FGF23 and MEPI that may alter bone mineralization. This slide here just kind of goes over the hormonal changes we see as chronic kidney disease develops. The first thing that actually happens, is noted by line number 1, is very early in the development of CKD, we get increases in FGF23. This is followed again with GFRs that are fairly normal with decreases in your calcitriol or 125 vitamin D production and release. Subsequently, as the GFR starts to get below 45 to 50, we then start seeing increases in parathyroid hormone. And actually, the last alteration we see is overt hyperphosphatemia that occurs rather late in the progression of CKD, generally in CKD stage 4 or stage 5. A lot of these earlier hormonal changes, the increase in FGF23, the decrease of 125 vitamin D, and the increase of parathyroid hormone are actually occurring to help us maintain normal serum phosphate concentrations. Well, I just want to get to the parathyroid hormone calcium axis here, and as we know, parathyroid hormone is the principal calcium regulating hormone, and it controls calcium balance by activating the receptor in the kidney and bone. Increased calcium reabsorption occurs in the thick ascending limb and the distal convoluted tubule of the kidney. It also increases the 1-alpha hydroxylase activity in the proximal tubule, and it indirectly increases osteoclast bone resorption in order to increase calcium into the body. The parathyroid gland actually senses the decreases in calcium by the calcium sensing receptor on the gland surface, and very small changes in the serum calcium ends up stimulating parathyroid hormone. This right here better demonstrates the relationship between ionized calcium and parathyroid hormone secretion. The graph, the line to the left, is actually what we see in normal individuals, and I want to note out that parathyroid hormone secretion never goes down to 0. We have a constitutive production of PTH, and as the calcium drops, that production of parathyroid hormone increases, and as calcium increases, the production of PTH and release decreases. We have the concept of the set point of PTH, which is the calcium concentration in which you get 50% inhibition of maximum parathyroid hormone secretion. In patients with renal disease and secondary hyperparathyroidism, as you can see by the line to the right, we get a shift in this set point to the right, and that it takes a higher serum calcium in order to inhibit parathyroid hormone concentration, or parathyroid hormone release. Again, looking at parathyroid hormone, here is a regulator of phosphate metabolism. You again see, as we have increasing parathyroid hormone, we do affect phosphorus in a couple ways. We initially affect phosphorus because the increased parathyroid hormone will actually increase bone resorption and will cause a release of serum phosphorus. The parathyroid hormone does help to enhance phosphaturia by enhancing phosphate excretion by the kidney. As noted there, we have FGF23, which is released by bone and acts to stimulate phosphaturia. But in addition, we have parathyroid hormone that stimulates the 125 vitamin D that helps to enhance phosphate absorption in the GI tract. So as you can see, there's a very complicated system of regulatory and counter-regulatory hormones including parathyroid hormone, calcitriol, and FGF23, that tries to maintain normal phosphate balance. In terms of the factors that contribute to the secondary hyperparathyroidism, again, as I mentioned, we have decreased kidney function. We get an increase of phosphorus, an increase of FGF23, and a decrease in calcitriol. That results in a decrease in our calcium absorption in the GI tract. Those factors actually affect the parathyroid gland, that you have a low calcium causing an increase in parathyroid hormone production, but we also have a decrease in the vitamin D expression and decreases in both the vitamin D receptor and the calcium receptor at the level of the parathyroid gland, so therefore it takes higher serum calcium in order to inhibit parathyroid hormone. With time, we get parathyroid gland hyperplasia, which then continues with further increase of parathyroid hormone secretion, and this feeds back to the bone where we get increased bone resorption. In terms of the absolute regulation at the parathyroid gland, again, as I mentioned, parathyroid hormone is constitutively released, and we basically have inhibitory factors. We have the calcium sensing receptor that acts to inhibit parathyroid hormone release. We have the vitamin D receptor, which also helps to inhibit parathyroid hormone release. And we also know that FGF23 will combine with its receptor and co-localize with closo, which also has an inhibitory effect on parathyroid hormone. So most of the factors that we have in terms of regulating PTH have to do with inhibition of its production and release. If we look at what happens in the evolution of CKD and hyperparathyroidism, we get progressive parathyroid hormone hyperplasia. Initially, with diffuse hyperplasia, you get a decrease in your calcium sensing receptor, your vitamin D receptor, and the receptor for FGF. With time, you start forming nodules, and as these nodules start to form, they become monoclonal, and they actually have a marked decrease in the calcium sensing receptor, the vitamin D receptor, and the FGF receptor. Therefore, as this disease progresses, this tissue and cells become totally unresponsive to its regulatory factors, the calcium, vitamin D, and FGF23, and it's almost like cancer biology, is that you have unregulated growth of the tissue as well as unregulated production of parathyroid hormone. So the question is, could we use hyperparathyroidism as a disease entity in and of itself, or is it a surrogate marker underscoring other diseases and pathologies? And in nephrology, this is one of the biggest things that we struggle with, whether we use parathyroid hormone as a marker or as a disease in and of itself. Well, in terms of surrogates, we do tend to use it as a surrogate of bone disease, and it is its major factor on how we assess whether patients have bone disease, and in particular, the incidence of fractures. We also have been looking at it in terms of surrogates of various outcomes of patients, such as hospitalizations, cardiovascular disease, and mortality, and most of the epidemiological studies have shown an association with high parathyroid hormone concentrations with poor patient outcome and mortality. There's multiple clinical manifestations associated with primary hyperparathyroidism, in the sense that they have looked at a disease, including the bone disease, classically osteoitis fibrosis cystica, as well as association with fractures, the development of kidney stones, hypophosphatemia, increased production of calcitriol, even to the point of having cardiovascular disease with hypertension and LDH associated with hyperparathyroidism in patients who have normal kidney function. Well, what about in secondary hyperparathyroidism in chronic kidney disease? And again, there seems to be associations with bone and or joint pain. The associations with fractures are not that clear-cut. Clinically, these patients do develop a proximal myopathy, and we do see spontaneous tendon rupture. Growth retardation in children. There's clearly, when the parathyroid hormone levels get high, we get extraskeletal calcifications, calciphylaxis. Because of the fibrosis in the bone marrow, it tends to make the anemia seen in CKD worse. There's evidence of neurotoxicity. Pruritus is a major problem, as well as cardiomyopathy has been associated with high PTH levels in patients with chronic kidney disease. So in terms of secondary hyperparathyroidism as a disease, we clearly have a lot of evidence. And I'm just showing you here a couple images of patients. This is a patient who presented to dialysis with severe hyperparathyroidism. And as you could look in the CT scan, you can see massive calcification within his sinuses, the protrusion of the jaw, and the loss of teeth. You can see here on the skull, it's got the classic salt and pepper characteristics we see with increased bone resorption. You can also notice the calcification of the ears, or the auricular calcification of the calcium B deposit there. And again, if you look at the upper jaw, you can see spaces between the teeth there as the erosion of the bone. Here is a classic brown tumor that is seen in patients with hyperparathyroidism. It looks very similar to the same types of lesions we see with multiple myeloma. And finally, we have the syndrome of calciphylaxis. This is the classic calciphylaxis we've seen with severe hyperparathyroidism, where you get basically occlusion of your small distal vessels, ischemia, and eventually necrosis. Other factors we see in the slide here is the auricular calcification in the shoulder in the upper left-hand corner. You can see this arteriole where we have massive medial calcification within this artery here, very common. These patients are a bit different than what we see with hypercholesterolemia and calcium plaques in the cholesterol, whereas here you have actual calcium laid down within the medial aspect of the vessel. Another patient here with extra calcification, as you can see, up in his shoulder. And finally, you can see the CT scan in the lower right-hand corner. Obviously, you can see the ribs and the spine there, and that yellow is the bone or the calcium. But if you look at his coronary arteries, they appear basically the same density as what we see in the skeleton of this patient. As I mentioned, there is association with parathyroid hormone and outcomes, and is shown here in patients prior to dialysis. You can see that the higher the parathyroid hormone concentration is, there is an increased risk of all-cause mortality. This is looking at dialysis patients. Again, Dr. Martin showed you the range of 150 to 300, which was the K-Doki range. And some of that was determined based on data like this, but you can see as the parathyroid hormone level gets above 300 picograms per milliliter, you can see an increase in mortality. Interestingly, we also see an increase in mortality with patients with very low parathyroid hormone concentrations. This is probably due to malnutrition and inflammation associated with these patients. So I want to just give a couple cases to give you some flavor of how we use PTH and how difficult it may be in its interpretation. This case here is a 42-year-old African-American male who'd been on hemodialysis for 15 years with a AV fistula. He actually does nightly home hemodialysis 5 times a week for 7.5 hours. So he's someone who is otherwise very well dialyzed and actually does not need a lot of medications because of that. As you can see, he is on some antihypertensive medications, phosphate binder, paracalcitol is a vitamin D analog, treat hyperparathyroidism, as well as cinacalcet, which is a calcium-sensitive mimetic. His physical exam is essentially unremarkable. Showing here are his labs, and I just want to point out his calcium is relatively normal. His phosphorus actually is not too bad for a dialysis patient, but is even above the 5.5 level that Dr. Martin pointed out. And as you can see, his parathyroid hormone level is well over 2,000. By his creatinine and BUN, you can see he's fairly well dialyzed. These ultrasound images are of the neck. It may be a little hard for you to make out, but you can see the image on the left shows a parathyroid nodule. Actually, it's a parathyroid gland that's markedly enlarged. Normally, you cannot see the parathyroid glands when you do an ultrasound of the neck. And to confirm that it's parathyroid, in the image to the right, you can see the marked increased blood flow when the color Doppler is put into it, as these glands tend to be very vascular. Well, just to give you an idea of how difficult it is to look at parathyroid hormone concentrations and to put what Dr. Martin showed you earlier into real patient care, you can see here are his labs over a 4-month period. And I just want to highlight the parathyroid hormone. Again, this was an intact assay with an upper limit of normal of 88. You can see that the values varied from month to month between 1100 and basically 2100, with very little changes in his calcium and phosphorus. So again, the issue of having good PTH assays and how we translate it into patients becomes somewhat difficult when we take it to individual patients. The second case is a 76-year-old Caucasian female with CKD stage 4 from diabetes and hypertension. She's had a couple low trauma fractures. Shown here are her medications. She's also on vitamin D as well as calcitriol, which is an active vitamin D. Her blood pressure is relatively normal. She's a frail woman, but not too remarkable in terms of the physical exam. Shown here are her labs. As you can see, her creatinine is 2.6, again putting her at about a stage 4 CKD. Her parathyroid hormone level is 173, clearly elevated from normal, but if she was a CKD stage 5, that would be in the target range. However, even to the guidelines that Dr. Martin gave you earlier, this would be high because CKD stage 4 we felt should have levels less than 110. Vitamin D levels are a little low. Her alkaline phosphatase is a little bit elevated. Calcium within range and phosphorus within range. And one would predict, based on this profile, that she would have hyperparathyroidism with hyperparathyroid bone disease. However, if we do a bone biopsy on her, as shown here, this is really a biopsy of low bone turnover. As you look along the bone trabeculi there, you see absolutely no cellular activity, no evidence of resorption or formation, and the reddish color area is that of osteoid, and that is rather minimal, and there's no evidence of marrow fibrosis or anything else. So in fact, she does not have hyperparathyroidism, but has rather low turnover, what we would call low turnover adynamic bone disease, and you would not want to aggressively treat her for hyperparathyroidism in spite of what her laboratories showed. So our clinical practice really has been to use the parathyroid hormone and as an indicator of bone disease. Again, Dr. Martin went over this earlier, giving you the KDOQI and KDIGO guidelines of PTH. Again, we focus mostly on stage 5. I will say that as these guidelines were developed, there was not a whole lot of evidence necessarily to support them. This is looking at parathyroid hormone concentrations from the dialysis outcomes practice group that scans all dialysis patients. And as you can see, with time, we've actually increased our parathyroid hormone concentrations from 2010 to 2013 as we've liberalized the area of having PTH levels up to 9 times the upper limit of normal. Again, we don't have any real good data saying whether this is good or beneficial for the patients or not. I just want to go into how we really look at bone disease, and that's by bone biopsies. In the center there, you can see a normal bone. There's a normal trabeculi. If you look at it, you do have an area of bone resorption as well as areas of bone formation and osteoid. In the upper left-hand corner is a classic picture of osteomalacia, where you have a large degree of unmineralized bone, and you may have both active bone resorption and formation going on. In the lower left is the adynamic bone, similar to the patient I showed you, where there's absolutely no bone cell activity and very little osteoid. In the lower right-hand corner is that of osteoitis fibrosis cystica, which is the classic lesion of hyperparathyroidism. You see a lot of bone resorption going on, as well as osteoid being laid down, and above that is something we've termed mixed uremic osteodystrophy, or a mixed lesion, where you have both osteomalacia, or lack of mineralization, as well as high turnover bone disease. Well, KDIGO has actually come out with a different way to classify what we call the TMV system, where we look at turnover, mineralization, and volume, and this is to better objectify our bone biopsies opposed to quality measures. And turnover could be either high, normal, or low, mineralization, normal or abnormal, and volume either high, normal, and low. If we look at the biopsies we had earlier, if you look at an adynamic bone here, you can see this one could be either low turnover, abnormal mineralization, because there's no mineralization in normal volume. The mixed lesion has high turnover, abnormal mineralization, because there's too much osteoid being laid down that's not being mineralized, in low volume. And the osteoitis fibrosis cystica would be a high turnover, again abnormal mineralization, but bone volume is actually increased. Well, we are using this to help classify. If we look at the classic classification system on what patients have in CKD, hemodialysis, and peritoneal dialysis, you can see about 2/3 of the hemodialysis patients have evidence of hyperparathyroidism, whereas there's a much larger percentage of patients with CKD and doing peritoneal dialysis that tend to have a lower bone turnover. If we look at, again, the use of parathyroid hormone to predict bone formation rates, as you can see here, the green area is the normal bone formation rate. It's very difficult that parathyroid hormone has been very helpful in us identifying patients with either low or high bone turnover. There's many confounders for the measurement of PTH, such as the dynamic metabolic state, including acidosis, the vitamin D status, as Dr. Martin mentioned fragments, oxidation, the effect of FGF23, calcium, phosphorus, magnesium, and dialysis, as well as specific therapy for parathyroidism, such as vitamin D analogs and calcimimetics, as well as there is a circadian rhythm for the secretion of PTH. In terms of another study trying to use PTH to predict bone disease, again, you can see that osteoitis fibrosis is associated with very high PTH levels, but you can also see there's a lot of overlap when you go to the very low bone turnover, where, again, it tends to be low, though you could have significantly high PTH in the ranges of patients with osteoitis fibrosis. I just want to wrap up here on a project that we've been involved in that was just published earlier this year. It was the KDIGO project, where we had some 500 patients' biopsies as well as parathyroid hormone concentrations. We had the intact parathyroid hormone concentration. We also had a parathyroid hormone concentration that was by the old system when the biopsy was obtained some 10 or 15 years ago, as well as the whole antibody, or the whole 1 to 84. And if you look here in terms of the correlations, there is a fairly good correlation with the intact PTH and the whole assay at 0.926. However, the correlation between the originally measured intact and the subsequently measured intact was not that good, nor was it with the originally measured intact and the whole biopsy. If we wanted to use PTH, again, by these different assays to discriminate low from normal to high bone turnover, again, looking at populations, it does look like we get a statistically significant difference between low, normal, and high using either the intact or the whole, as well as using bone-specific alkaline phosphatase or teleopeptides. But again, there's a lot of overlap, as I showed you before. If we really wanted to discriminate, we did do receiver-operated curves and area under the curves, trying to discriminate bone turnover by serum biochemistries. This is looking at low versus normal or high versus normal, and the numbers may be hard, but you really want to have an area under the curve of at least 0.7 to 0.8 to be somewhat helpful. 0.7 is just minimal. And as you see here, only bone-specific alkaline phosphatase to discriminate low from normal bone turnover was helpful in at a 0.76, with a cutoff being either above or below 33.1 units per liter. All the other biochemical measurements in terms of differentiating low from normal or normal from high were actually not helpful. Shown here is just looking at low versus non-low or high versus non-high. And at least here, when we look at all the parathyroid hormone assays and the bone-specific alkaline phosphatase, we do get an area under the curve of at least 0.7. However, to really, according to most statisticians, to be helpful, you really would like to see this at 0.8. And the combination of PTH with bone-specific alkaline phosphatase did not necessarily help. Again, looking at this project, looking at both specificity and sensitivity, you can see that our positive predictive values by using either the K-DOKI guideline, which is 150 to 300, or the K-DIGO guideline, which is up to 9 times the upper limit of normal, is not very robust, except for the negative predictive value differentiating high from non-high bone turnover in this patient population. So I thank you for your attention, and I hope you appreciate some of the difficulties that we're now dealing with in using parathyroid hormone to help us assess our patients.
Thank you both, Dr. Martin and Dr. Sprague, for bringing us this informative presentation. It's time for our Q&A now. I'm just going to remind our audience, if they have a question, click the green Q&A button at the lower left of the presentation window, type in your question, and we'll try to get to as many as we can. We do have one question in our queue already. We have a question from an audience member. What length of time of having hyperparathyroidism does it take for the calcification of the shoulder? In the photo you showed, how long would a patient have to have hyperparathyroidism for that to occur?
The patient who had the hump above his shoulder was actually a relatively young guy. He was in his 30s, and he had renal failure for about 10, 12 years. His PTH levels were up in the 2000s, not very well controlled. The one that had the calcification within the shoulder was a bit older and was also about 10 to 15 years on dialysis, again with PTH levels in the 2,000 to 3,000 range. These patients also tended to have relatively poorly controlled serum phosphates. And the one that had the calcification above his shoulder actually also was hypercalcemic. But I think you're talking about, clearly more than 6 to 10 years of not well-controlled disease.
Thank you for that answer. I'm just going to check our queue to see if we have any more incoming questions. I don't see any, and we are just about out of time. I would like to once again thank Dr. Martin and Dr. Sprague for teaming up for this presentation. Do any of you have any final comments for our audience?
I think we don't really at the present time. It's I hope what we've shown is it's a difficult area to put the lab work and the clinical work together, and it's the variability in the assays continues to be a problem, and hopefully we'll be able to continue to work on that and bring it to some kind of formal resolution, hopefully in the not too distant future.
Thank you so much. Once again, I'd like to thank Dr. Sprague and Dr. Martin, and of course thank our sponsor, Siemens Healthcare Diagnostics, for making today's educational webcast possible. Before we sign off, I want to let everybody know that today's webcast will be available for on-demand viewing through May of 2016. Attendees for today will receive an email from LabRoots letting you know when that webcast is available for replay, and we would invite you to please share that announcement with your colleagues who may have missed today's live event. Once again, thank you to Dr. Martin and Dr. Sprague, our sponsor, Siemens Healthcare. We hope to see you again. Thank you for joining us.
Thank you.
Thank you.